Welcome to the hemostasis lecture on coagulation factors. There are 12 factors involved in coagulation. They are numbered with Roman numerals 1 through 13. No, there is no mistake because there is no factor 6. Almost all of the factors are proteins with the exception of factor 4, which is a mineral, calcium, more specifically ionized calcium. There are also other substances that are required for coagulation to occur, such as phospholipids, which come from platelets. Many of the coagulation factors exist in circulation as inactive enzyme precursors called zymogens, or procoagulants, while others function as cofactors. As you are looking at the slide, you will undoubtedly notice that 4 cofactors, or accelerators, are listed. Factor 3, Factor 5, Factor 8, and HMWK. And by the way, HMWK stands for high molecular weight kininogen, also known as Fitzgerald factor. HMWK is one of a handful of substances required for coagulation to occur, but is not assigned a Roman numeral. This is because HMWK belongs to the kinin-kallikrein system, or just simply the kinin system. It consists of blood proteins that play a role in inflammation, blood pressure, coagulation, and pain. All of these enzymes and cofactors begs the question, what substrate are they acting on? Good question. The ultimate goal of coagulation is to form a fibrin clot. In order to accomplish this, the substrate, fibrinogen, or factor 1, must be converted to fibrin. Of the factors that are enzymes, many are classified as serine proteases and require vitamin K for synthesis. These include factors 2, 7, 9, 10. A few of the factors are classified as glycoproteins, which include factors 3, 5, and 8. Factor 13, fibrin stabilizing factor, is a transaminase, specifically transglutaminase. All of these factors are synthesized in the liver, with a few exceptions, of course. Factor 3, tissue factor or tissue thromboplastin, factor 4, ionized calcium, and factor 8. Actually, factor 8 is composed of 2 subunits, factor 8C and factor 8 VWF. The former is produced in the liver, but the latter is produced in the endothelium as well as megakaryocytes stored in alpha granules of platelets. Factor 3, or tissue thromboplastin, is a mixture of substances which includes phospholipids. The clotting factors can be organized into 3 groups: the fibrinogen group, the prothrombin group, and the contact group. The fibrinogen group are thrombin sensitive and consists of factors 1, 5, 8, and 13. The prothrombin group are vitamin K dependent and consists of factors 2, 7, and 10. Being that they are vitamin K dependent, they are susceptible to warfarin therapy, which inhibits vitamin K. The contact group are not vitamin K dependent and consist of factors 11, 12, PK, or prekallikrein, and HMWK, high molecular weight kininogen. Factors in the fibrinogen group, as well as factor 2, are consumed during clotting. Factors 5 and 8 are both labile and will decrease in stored blood. The first clotting factor is factor 1, or fibrinogen. It is a globular protein and is soluble in water. Fibrinogen, like many other clotting factors, is synthesized in the liver and is not vitamin K dependent. It becomes activated by activated thrombin, becoming activated fibrinogen. The 2 primary disorders associated with fibrinogen are hypofibrinogenemia and afibrinogenemia. The reference range for fibrinogen is generally 200 to 400 milligrams per deciliter. The second clotting factor is factor II, or prothrombin. It too is a globular protein and is one of several serine proteases. It is vitamin K dependent and is also synthesized in the liver. Prothrombin is activated by factors 10A and 5A, becoming thrombin, or factor IIA. The reference range for prothrombin is generally 8 to 15 milligrams per deciliter. The third clotting factor is factor III, tissue thromboplastin, or simply tissue factor. Factor III consists of a group of substances that are high molecular weight lipoproteins derived from body tissues. Technically, there are two types of thromboplastin. Thromboplastin from platelets is called plasma thromboplastin, or platelet factor III, as opposed to tissue thromboplastin released by damaged endothelial cells that line the vascular system. These two types of thromboplastin are involved with different clotting pathways. Tissue thromboplastin is associated with the extrinsic pathway, while platelet factor III is associated with the intrinsic pathway. We will discuss platelet factor III more when we get to factor IX. Factor VII becomes activated to factor VIIa upon exposure to damaged tissue, which contains tissue factor. The fourth clotting factor is factor IV, or calcium, more specifically ionized calcium. Calcium is required to activate thromboplastin, a mixture of both phospholipids and tissue factor, and helps to catalyze the conversion of prothrombin to thrombin. Calcium also helps to amplify the clotting process by bridging platelet phospholipids and clotting factors. The fifth clotting factor is factor V, proaccelerin, or labile factor. It is a globular glycoprotein synthesized in the liver. As the name implies, it is labile and degrades easily. Factor V is activated to accelerin by thrombin and serves to amplify the clotting process by activating more thrombin, which in turn activates more accelerin, and so on and so on. The deficiency of factor V is associated with increased bleeding. A mutation exists called factor V Leiden. This mutation does not allow the activated protein C and protein S complex to neutralize accelerin, which leads to thrombosis. The next clotting factor is factor VII, also known as proconvertin, or stable factor. What happened to factor VI, you ask? Remember, there is no factor VI. It doesn't exist. So factor VII. This is another globular protein that is a serine protease. It is vitamin K dependent and is synthesized in the liver. It is activated to convertin by tissue thromboplastin, essentially factor III. Factor VIIa in turn activates factor X to factor Xa. The eighth clotting factor is factor VIII, also known as antihemophilic factor. The gene for factor VIII codes for production of two protein subunits. The first subunit is a large glycoprotein which circulates in plasma and associates with von Willebrand factor in a non-covalent complex. Free, unbound factor VIII is unstable except during coagulation. Factor VIII is labile and deteriorates over several hours in stored blood, despite being bound to von Willebrand factor. The second subunit is a small protein which consists primarily of the phospholipid binding domain of factor VIIIc. This binding domain is essential for coagulation to occur. The factor VIII-C subunit is a cofactor for activated factor IX, required to catalyze the conversion of factor X to factor Xa. A deficiency of the factor VIII-C subunit corresponds to classic hemophilia A. The larger subunit, 8-VWF, aids in the adherence of platelets to the subendothelium. Platelets are activated when they come into contact with damaged tissue by exposure to collagen. Low levels of thrombin are also generated through this adherence to exposed collagen. In addition to activating more platelets, thrombin activates factor VIII and causes it to dissociate from von Willebrand factor. Once it dissociates from the complex, it is free to interact with factor IXA. It is a cofactor to factor IXA in the activation of factor X, which in turn, with its cofactor 5A, activates more thrombin. Thrombin cleaves fibrinogen into fibrin, which polymerizes and cross-links, using factor XIII, into a clot. No longer attached to von Willebrand factor, activated factor VIII is proteolytically inactivated by activated protein C and factor IXA and quickly cleared from the bloodstream. I cannot explain the bullet point not involved in coagulation, so I'm going to skip it. Factor VIII is synthesized and released into the bloodstream by various tissues, including the endothelium of the vascular system and the kidneys, both glomerular and tubular endothelium, and the sinusoidal cells of the liver. The majority of circulating factor VIII exists as the factor VIII von Willebrand factor complex. The antibiotic ristocetin induces platelet aggregation in the presence of the factor VIII von Willebrand factor complex. Therefore, it is often used in assays to determine von Willebrand factor activity. Hemophilia A is a recessive X-linked coagulation disorder. Seeing that this is an X-linked and recessive disorder, it is more commonly seen in men, where only one X chromosome is present. Recessive means that the condition is only expressed in the homozygous form. If a woman possesses only one affected X chromosome, she is said to be a carrier. This is because in the heterozygous form, the condition is asymptomatic. However, if both X chromosomes are affected, homozygous, then hemophilia can be manifested. Classic hemophilia A is a bleeding disorder caused by a deficiency of the factor VIII-C subunit. The degree of deficiency is associated with the severity of the disorder. Patients with hemophilia A have normal levels of the factor VIII von Willebrand factor subunit. However, because factor VIII depends on von Willebrand factor for stability, individuals with von Willebrand disease who have a von Willebrand factor deficiency also show decreased factor VIII activity. Patients with hemophilia A typically have a normal bleeding time but a prolonged APTT, or activated partial thromboplastin time. The bleeding time is an antiquated test that is used to screen for von Willebrand disease and abnormal platelet function. It is still sometimes performed. The last time I performed a bleeding time, I used the IV method. That was in 1995 while I was working at Tuolumne Community Hospital. The IV method is the traditional method used for this test. While both the IV and the Duke method require the use of a blood pressure cuff, the IV method is more invasive than the Duke method, requiring an incision on the ventral side of the forearm, whereas the Duke method involves puncturing either the earlobe or finger with a lancet. For the Ivy method, the blood pressure cuff is placed on the upper arm and inflated to 40 millimeters of mercury. A lancet or scalpel blade is used to create a standard-sized incision that is 10 millimeters long and 1 millimeter deep on the underside of the forearm. Every 30 seconds, filter paper is used to draw off the blood without displacing the incision, which could disrupt the clot and falsely prolong the bleeding time. The test is finished when bleeding has stopped. The time from when the incision is made until all bleeding has stopped is measured and is reported as the bleeding time. Mixing studies are one way to screen for hemophilia A. Mixing patient plasma with normal plasma in a 1-to-1 ratio will correct a patient's prolonged APTT if they have a factor deficiency, such as factor VIII. However, if the patient has an acquired deficiency due to an antibody deactivation or a factor inhibitor, the mixing study will not correct the prolonged APTT. Von Willebrand factor is a multimeric glycoprotein composed of multiple subunits. The subunits are produced by endothelial cells and megakaryocytes, where they combine to form larger multimers. Von Willebrand factor multimers are stored in the alpha granules of platelets and in endothelial cells. The multimers are released from storage into the plasma where they circulate. The general reference range for von Willebrand factor is 7 to 10 micrograms per milliliter. Von Willebrand disease is a hereditary condition that affects primary hemostasis, or platelet adhesion, and thus patients will exhibit abnormally prolonged bleeding times. There are 3 types of von Willebrand disease. The most common is type 1, which is a deficiency of von Willebrand factor. There are several subtypes of type 2. Patients with type 2A exhibit abnormal von Willebrand factor multimers, with only the small multimer being present, which results in poor binding to platelets. Type 2B manifests as abnormal von Willebrand factor with an increased binding to platelets. This results in a very rapid clearance of both platelets and multimers. Type 2M is a decreased binding of von Willebrand factor to primary platelet surface receptor for von Willebrand factor, GP1B. This results in a decreased ability of platelets to adhere to the endothelium. Type 2N is a mutation of the von Willebrand factor binding site to factor VIII. This results in a decreased binding to factor VIII, which is then rapidly cleared by the liver. This type of von Willebrand disease also goes by the name autosomal hemophilia. Finally, type 3 is the absence of von Willebrand factor. This is the homozygous form of type 1. The next clotting factor on our tour is factor IX, plasma thromboplastin component. Factor IX is a stable globular protein synthesized by the liver and is vitamin K dependent. It is activated by factor 7A and factor 11A. Factor IX is called plasma thromboplastin component because it requires the cofactor, factor 8A, plus platelet factor 3, plus ionized calcium, in order to activate factor 10. Basically, platelet factor 3 is the platelet thromboplastin that circulates in the plasma as opposed to the tissue factor, tissue thromboplastin that comes from the endothelium. Factor IX is sometimes referred to as Christmas factor. This is due to its discovery in 1952 after a young boy named Stephen Christmas was found to be lacking this factor. Factor IX deficiency leads to hemophilia B. Hemophilia B is an inherited X-linked recessive coagulation disorder. Over 100 mutations of the factor IX gene have been discovered. Depending on the specific mutation, symptoms may be either mild, moderate, or severe. Factor X is also known as Stewart-Prower factor. This factor is another stable globular protein synthesized by the liver that is vitamin K dependent. In the intrinsic pathway, it is activated by factor IXA along with cofactor VIIIa. In the extrinsic pathway, it is activated by factor VIIa and ionized calcium. Factor XI, also known as plasma thromboplastin antecedent, or PTA, is a globular protein that is only partially consumed during clotting. It too is synthesized by the liver. However, it is not vitamin K dependent. It circulates complexed with high molecular weight kininogen and is activated by factor IIa, thrombin, and factor XIIa, Hagman factor. Activated factor XI activates factor IX, plasma thromboplastin component. Factor XI deficiency leads to hemophilia C. Factor XII, or Hagman factor, is a stable globular protein that is also synthesized by the liver and is also not vitamin K dependent. In vivo, it becomes activated when exposed to damaged endothelium. In vitro, it is activated by exposure to glass, which carries a negative charge. Due to its activation upon contact with glass in vitro, factor XII is also known as contact factor or glass factor. Of course, we don't have glass circulating in our blood, I hope. Therefore, exposure to activated platelets and or damaged endothelium activates factor XII in vivo. Activated factor XII activates factor XI. Oddly enough, patients with a factor XII deficiency are usually asymptomatic. Factor XIII, or fibrin stabilizing factor, FSF, is a fibrinase enzyme. There are two subunits of factor XIII. Subunit alpha is synthesized by megakaryocytes and is known as platelet factor XIII. Subunit beta is synthesized in the liver and is called plasma fibrin stabilizing factor. Factor XIII is activated by thrombin and catalyzes fibrin polymerization. So, whereas thrombin converts fibrinogen to fibrin monomers, factor XIIIa catalyzes the formation of covalent bonds between adjacent fibrin monomers. You see the next slide for the diagram. Multiple crosslinks form to produce an insoluble meshwork of fibrin polymers, the matrix of a blood clot. Factor XIII cannot be tested for by the PT, protime or prothrombin time, or the APTT. Prekallikrein, PK, is also known as Fletcher factor. PK is the precursor of plasma kallikrein, which is a serine protease that activates kinins. Prekallikrein is synthesized in the liver and is also not vitamin K dependent. It is then secreted in the blood, mainly complexed with high molecular weight kininogen. PK is cleaved to produce kallikrein by activated factor 12. Prekallikrein, upon activation to kallikrein, is responsible for breaking down high molecular weight kininogen to bradykinin, which is a potent vasodilator. Kallikrein also initiates fibrinolysis by activating plasminogen. It also plays a role in activating complement and helps recruit phagocytic cells. And now the last factor. Drum roll please. High molecular weight kininogen, also known as Fitzgerald factor. High molecular weight kininogen is synthesized in the liver and is not vitamin K dependent. Kininogens are multifunction proteins with antithrombotic, antidiuretic, profibrinolytic, antiadhesive, antiangiogenic, and pro-inflammation properties. High molecular weight kininogen is converted to bradykinin by plasma kallikrein. High molecular weight kininogen is a cofactor for reactions associated with factor 12 and a cofactor for activation of factor 7. Bradykinin, released from high molecular weight kininogen, induces hypotension and causes natriuresis and diuresis. Bradykinin also mediates inflammation, increases vascular permeability, induces vascular dilation, and stimulates pain receptors. I strongly suggest completing the following activity: building a table with coagulation factors, alternative names, site or sites of synthesis, vitamin K dependency, type of molecule and function, and associated disorders. Oh, and don't forget to have fun.